Okay. I would like to thank Cantel Medical to permit me to be here with you this afternoon and talk about my experience with SubCyclo in the glaucoma treatment. So, my colleague have given us the details about micropulse laser, which uses the same technology like SubCyclo. So in the introduction, I will repeat some information. So the glaucoma is an optic neuropathy, which changes in optic nerve head and vision field defect. And there is a variety of factors, and also the level of IOP is one of the most important factor risk. So we have a large arsenal to control the IOP level and reducing the production of aqueous humor or increasing the aqueous outflow in the aim to preserving optic nerve function. So in the current practice, we treated glaucoma step by step, depending on the severity of glaucoma, and generally, cyclodestruction and valve is reserved for refractory and advanced glaucoma. We have many methods to cyclodestruction. Among them, the transscleral cyclophotocoagulation with the continuous wave of DIODE laser seems to be effective, but due to the side effect, the severe side effect like uveitis and phthisis bulbi and vision loss, this method is reserved for refractory glaucoma. This laser seems to be effective thanks to his good transmission through the sclera and his good melanin absorption. And recently, another DIODE laser delivery mode has emerged to treat efficaciously the glaucoma, so without collateral damage. We have many there is many mechanisms to reduce the glaucoma, to reduce the IOP with SubCyclo. Some of the mechanism reduce the production, and some of them increase the aqueous outflow. A recent hypothesis is there is a modification in the position of the sclera spur and the trabecular meshwork, which open the angle. So, in contrast to the conventional cyclophotocoagulation, where a continuous wave of a high intensity was delivered, the SubCyclo produces an ultra short and repetitive pulses. It corresponds on time on, and followed by long cooling time corresponding on time off. The cooling time avoid energy to build up, and the targeted tissue can be cool between pulses, between laser pulses, and avoid the apparition of necrosis, coagulative necrosis, and tissue damage. So I'm going to tell you about our studies. We have two studies in the aim to evaluate the efficacy, the tolerability, the side effect, and anatomical effect with UBM, using the SubCyclo with a dirty cycle of 25% in the first study, and with 31.3% in the second study. In the first study, 43 eyes of 34 patients were treated by SubCyclo with dirty cycle of 25%. In the Glaucoma Institute of Saint-Joseph Hospital at Paris from April 16 to April 17. It included all types of glaucoma, open or closer or secondary glaucoma. The majority of them were in the advanced stage, but some of them were in the moderate stage. The treatment was indicated after failure of other therapeutics or when there is a high risk of surgery. In the second study, 26 eyes of 24 patients were treated with SubCyclo cycle 31.3% from July 17 to December 17. The procedure after asepsis by betadine and the placement of an eyelid speculum, we use a subtenon anesthesia or a peribulbar block with 2 or 3% of lidocaine without epinephrine. We used infrared laser, about 810 nanometers, and with a new probe which produces fast pulses. In the device, we selected the mode, the SubCyclo mode, and the laser settings were a power of 2,000 milliwatts, and a duty cycle in the first group 25%, and the second group 31.3. The duration was selected as 100 seconds for the first group and 160 for the second group. And the probe was applied at 3 millimeters posterior from the limbus and maintained perpendicularly through the sclera, and it's moved in sliding arc from 10 o'clock to 2 o'clock in the superior area and 4 o'clock to 8 o'clock in the inferior area, avoiding the meridian of 3 o'clock and 9 o'clock. This movie showed the procedure. Oh. C'est pas mis en route. Ah. Here it's the location, 3 millimeters from the limbus. In the superior and inferior. We can use subtenon anesthesia or periocular block. And it's so easy to move with this probe. A new BM was performed for 10 patients to evaluate the anatomical changes after laser. And post-operatively, a topical prednisolone was prescribed 4 times a day for 1 or 2 weeks, depending on the anterior chamber reaction. The pre-treatment glaucoma medication were continued. So the follow-up examination were followed at 1 day, 1 week, 1 month, 3 months, 6 months, 9 months, and 12 months. The relative success was defined as an IOP maintained less than 21 millimeters or less than or an IOP reduction of 20% or more. This table shows the average of age and gender in two groups and the different type of glaucoma we treated. Then this table means the results. In the first group, it showed a reduction and decrease in the IOP at the day 1 and the day 7, then followed by stabilization, and it showed a reduction about 35% at the end of the follow-up. In the second group, it showed a reduction about a decrease of IOP at day 1 and day 7. The IOP reduction was more efficient in the group treated by DIODE 21.3%. It's followed by a period of stabilization, and it showed an IOP reduced about 40%. We have a reduction in the mean of number medication after laser. In UBM, hasn't shown any anatomic damage or visible images. In some cases, we can see a tiny space between sclera and the cellular body. It may correspond of suprachoroidal fluid. And we haven't found a severe complication. Only some retreatments, some cases of retreatments, and more inflammation in the group treated by DIODE cycle 31.3%. So our study reports a significant and fast IOP reduction after a week, and then followed by stabilization, eliminated the complication and side effect, and minimal anatomical modification, a reduction of medication, and better IOP reduction with SubCyclo 31.3, but more anterior chamber inflammation. So there are several studies who showed the effectiveness and the safety of the Iridex laser, which uses the same technology and same laser as SubCyclo. But a recent study showed some inflammation, some persistent inflammation with the Iridex. The Iridex. So it can be SubCyclo, can be safety and efficacy to treat glaucoma, and in my experience, I can use it, and I use it in the different stage of glaucoma and with different levels of IOP. That SubCyclo with DIODE cycle about 31.3 can be more efficient, but I used SubCyclo with DIODE cycle 25% in these following cases in order to avoid any complications in early disease, in inflammatory disease, and in some retreatments. It's a good option. The SubCyclo is a good option in the treatment of glaucoma, but it can be replaced SLT and can be combined with it to improve the reduction of IOP. Thank you very much.